Hello, and welcome to our discussion about alternative service delivery models for genetic counseling. The opinions expressed by the genetic counselors are theirs only and do not represent the opinion of AstraZeneca. The opinions expressed are not approved messages. You may not copy, reproduce, republish, upload, transmit, prepare derivative works, sell, transfer, license, or commercially use any part of this meeting. This presentation does not discuss or promote any investigational or approved drugs and does not refer to drugs by their brand names or to commercial entities. I'm Brian Reyes, Manager of Cancer Genetics at UT Southwestern, and I'm a current co-chair of NSGC's Access and Service Delivery Committee. The purpose of this discussion is to highlight two different genetic counseling alternative service delivery models, the challenges or barriers faced by the genetic counselors when implementing these models, and how these models have led to a larger number of appropriate patients receiving genetic testing. I'll turn it over to my two colleagues and allow them to introduce themselves. Jill, we'll start with you.
Great, thanks. So my name is Jill Stauffer. I'm a licensed genetic counselor, and I'm the Associate Director of Genetic Counseling at the Dana-Farber Cancer Institute in Boston, Massachusetts. Dana-Farber is a large academic medical center. We have 30 genetic counselors that practice purely in the oncology space, both in the adult setting and in the pediatric setting as well. We service all of New England, and we have a number of international patients that we serve as well.
And Morgan?
Hi, my name is Morgan Daly. I am also a licensed genetic counselor, and I am the genetics manager and one of the cancer genetic counselors at Franciscan Health in Indianapolis. Franciscan Health is a large community-based hospital. Our largest campus is on the south side of Indianapolis in more of a metropolitan area. However, we have several satellite facilities in more rural locations with a more underserved patient population.
Jill, Morgan, thank you so much for joining us today. As we get started, we wanted to ask a little bit about how you rolled out these service delivery models at your institution and what prompted you to do so. What was the challenge you were facing in your standard workflow? Jill, we'll start with you.
At Dana-Farber and everywhere now in the country, we're recognizing that increasingly newly diagnosed cancer patients are excellent candidates for germline genetic testing just based on their diagnosis alone. We know all pancreatic cancer patients, all patients with high-risk prostate cancer, ovarian cancer patients, lots of colorectal cancer patients, breast cancer patients. That's a lot of newly diagnosed individuals who could benefit from access to this germline genetic testing that increasingly informs upfront care, right away. And so we were being inundated with requests to see these patients quickly and really unable to meet the demand. And so we tried to think of a way to provide access to this patient population in a way that they were still going to be able to receive the proper information upfront to truly make a decision about genetic testing, to obtain informed consent. And so we developed a process through which our schedules are screened in advance by our new patient coordinators for appropriate patients for the rapid access process. And what we came up with is a process that involves providing a lot of the education around genetic testing by video. And we crafted an 8-minute video that goes through what the issues are that are required for informed consent. We wanted to make the video non-threatening, and the animation lends itself to that kind of overall feel. We wanted to make it accessible to as many people as possible, and so the animated version makes it easy to translate into a variety of different languages as well. We sought input from genetic counselors, geneticists, oncologists, multidisciplinary professionals, as well as from teams of patients who themselves reviewed the video for content and suggestions for clarity. And it continues to evolve. Even today, our version now I think is really well done. And we're working on our next version with another research initiative to make this type of pre-test video even more accessible for those who have low literacy and for those whose preferred language is Spanish. And so I suspect that there will be a library of these videos available to enhance education in this pre-test setting. And then this process was navigated by a new member of our team that we call genetic testing coordinators. And so all of this has allowed us to see a vast number of patients that we would not have had bandwidth to see up front. And then on the back end, we see those who are positive in our clinic. And so it's really an effort to deliver an increasing number of patients care up front that they need, right away, in a way that makes the service, acceptable and accessible.
Morgan, your program took a different take. Tell us a little bit about what you did at your practice.
Yeah, so similar to Jill, we were also noticing that more and more patients are needing genetic test results, at the point of diagnosis. And specifically within the breast cancer population, the issue we were facing is that we only have a team of 3 cancer genetic counselors at our largest facility, and we were struggling to get these patients scheduled to see a genetic counselor, soon enough to get genetic testing initiated, to get those results back in time for that surgery date in order to make the best surgery decision for that patient. And so the alternative service delivery model we implemented involves physician-directed genetic testing at the time of breast cancer diagnosis. So when a newly diagnosed breast cancer patient meets with their breast surgeon at that initial consult, their breast surgeon does discuss genetic testing with them and the importance of that testing, the benefits and limitations of doing so. And if a patient decides that they would like to pursue it, and most of these patients do decide that they want to pursue genetic testing, they have blood drawn at that time, testing is sent out, and then they're still encouraged to meet with a genetic counselor on the back end to review their results with them and offer additional genetic testing if appropriate.
These are both such great programs that address almost a very similar need, it feels like. You have large numbers of patients that need access to quality care, quick results. Morgan, your practice took a slightly different approach, and you got breast providers specifically involved, but you also included nurse navigators. Can you tell us a little bit about how you integrated them into your process?
Yes, definitely. So our breast nurse navigators have been instrumental in making sure that this workflow has been, smooth and helping to facilitate, identification of patients that need genetic testing offered to them. We also have them call out the breast cancer stat panel results when they're back so that patients receive those results at the first possible opportunity. The other way our breast nurse navigators have been incredibly helpful is providing the patient with information at their initial appointment on what a genetic counseling appointment is, why it's still recommended that they show up to that appointment even if their results are normal or negative. It talks about cost and different frequently asked questions from patients. So just providing that with the rest of the patient information to kind of help answer some questions that might arise.
Well, it sounds like both of you have really created these incredible, robust processes, and I can only imagine that one of the first things you had to do was talk about what results looked like at the endpoint. It's such a huge part of what genetic counselors are involved in. So I'm so curious, as we talk about these, what does the results disclosure process look like? How involved are genetic counselors? And if you don't mind, tell us a little bit about how the test is selected for the people listening. Morgan, we'll start with you.
So we have our breast surgeons ordering the breast cancer stat panel, which is a 9-gene panel that looks at the most high-risk breast cancer genes, which typically can change surgical decisions if a patient were to return positive for a mutation in one of them. Patients are, very happy to have that, piece of their care taken care of at their initial consult appointment with their breast specialist. Our breast nurse navigators have been, invaluable in this process, and they do a great job of actually disclosing those results to the patient over the phone once they're back. So they're able to, again, communicate those results, as quickly as possible to the patient, and then they still remind them at that time, hey, even though, let's just say your results are negative or normal, it's still important to meet with a genetic counselor because they're going to take your family history, they're going to talk about, potentially additional genetic testing that may be appropriate for you. Once we see the patient for, post-test genetic counseling, and once we take a thorough family history, that's when the genetic counselor kind of talks with the patient about additional expanded genetic testing options, which can kind of vary based on what kind of cancers we see in a patient's family history.
Okay, so it sounds like you're starting with a fixed option, and then they have the opportunity through expanded genetic counseling, but optional to the patient. So the patient has some autonomy to be involved in the process of what this looks like for them.
Exactly. And most patients, we do see on the back end for genetic counseling, but I would mention that we don't see all of them. And so some of these patients either decline to schedule a post-test genetic counseling appointment, or they don't show up and they, don't reschedule. But we feel that there is enough information given to that patient up front about, that 9-gene panel that they're having done, that they're appropriately consented to it, and that they have the most important genetic test results that they need in order to inform surgical decision making. So certainly they do take part, patients do have that autonomy to decide, whether or not they want to come to that genetic counseling appointment and whether or not they want any additional genetic testing.
But very much a patient-driven process, and
Exactly.
I imagine that works really well.
Yeah, it does.
Jill, how does that compare to what your group has been doing?
In our practice, again, we're seeing a very diverse set of patients with different diagnoses. And so we have guidance for our genetic testing coordinators who are ordering this test by diagnosis. So there's a planned lab, based on that diagnosis. And in general, all of our testing is broad panel testing. We do try to obtain family history information ahead of time via progeny family history questionnaire. Some patients fill it out, many do not. Understandably at this point in their diagnosis, there's a lot going on. Our genetic testing coordinators know how to obtain a 3-generation pedigree, but they're not trained genetic counselors, and so we do order broad panels for our participants. Typically, we're across the board ordering broad panels with the stat when it's available. When the results are back, then the results are communicated by our genetic testing coordinators, both to the oncology team immediately through the electronic record, and as well to the patient. And it gets pushed out through our electronic gateway, our patient portal, and then it also gets sent through the mail in case someone's not checking their portal. If the result is positive, if a pathogenic variant is identified, then those results are called out by a licensed genetic counselor. And those can be hard to call someone that you've never met before. And yes, it's happened to all of us that out of the blue we have a new CDH1 positive patient that we've never met, and we have to call this out. As the team discusses, it's never an easy result to give, no matter what, even if we're on the list of considerations. Some results are just harder than others. So positive results or concerning variants are communicated by our genetic counselors, and then anyone who has a clinically significant result is recommended to come back in and meet with both a genetic counselor and a genetics physician. And then we do long-term follow-up care for those who are found to have gene mutations.
I imagine that doing some larger panels means that you may experience more variants of uncertain significance. What do you do at your center to kind of handle those? How does that work?
So, we all know most variants of uncertain significance will end up being just normal variability that has no clinical significance. However, there are a subset of variants that are more interesting than others. And so what our center came up with was a way for our genetic testing coordinators to take the VUS results, search the ClinVar database, and see, does any lab call this variant either likely pathogenic or pathogenic? And if there's any designation by any lab in the world in ClinVar that calls it so, then the case gets escalated to a genetic counselor who will further scrutinize the result and then, typically be the one to call them out. So we have pulled out some results that way that have ended up being followed differently. And I think, again, as genetic counselors, that's happened to us all before as we see a variant and think, gee, that one looks a little more interesting, than a typical one. And so this process has been very helpful to us in not, letting those go by the wayside when they need further follow-up.
There's a double check in place to make sure that's getting done. I imagine, Morgan, you talked us through that there are navigators and a process in place. We didn't touch too much on positives. Is that similar to what Jill's group is doing?
So when a patient returns positive on that initial stat panel, they're still called by a breast nurse navigator that discloses that positive result, and then, strongly recommended to meet with a genetic counselor who will review that result in more detail with them. So we have seen all of our positives, on the back end for post-test counseling to, do a deep dive into what that result means for that patient in the context of their personal and family history.
So it sounds like there's been a strong uptake of people who are positive seeking additional genetic counseling at the recommendation.
Yes, absolutely. And I think in this patient population too, tends to be, very motivated, very information seeking, really receptive to learning as much as they possibly can about this information, because it's going to impact not just their surgery and treatment potentially, but also very much, can impact other family members as well.
We're curious, what does satisfaction look like, both for patients, but also for your teams after you have rolled out these alternative service delivery models? And Jill, we'll start with you.
We've had now approximately 3,000 people go through the rapid access process. And we have, in the last year, we conducted surveys for both the providers whose patients are having the rapid access, so the medical oncology and surgical oncology providers. We surveyed the genetic counselors to see what this process was like for them, and what were some pain points for them and what might be improved. We surveyed the genetic testing coordinators, and we also surveyed patient population who had been through the rapid access process. And we were very interested in what feedback we would get. Overall, this process is very well received. I think everyone's on the same page that the critical piece here is that patients get access to treatment decision-making information as quickly as possible.
Morgan, in your practice, I imagine that collecting satisfaction has also been equally important. Tell us what that looks like for you as a practice manager.
We haven't formally rolled out like a satisfaction survey, but anecdotally, the satisfaction has been tremendously improved for patients, for the breast specialist team, and even for our genetic counselors. Initially, our patients were sometimes frustrated. They a lot of times knew that they wanted and needed genetic testing, but they were frustrated if they weren't able to get in within a week or two, or they were frustrated that they needed to make yet another appointment on top of everything else on their plate to do something that, again, they felt was well within the scope of their breast surgeon. With our providers, their satisfaction has also improved because they too were frustrated when they didn't have that information back in time in order to help their patient make the best possible surgery decision for them. And then among our team of genetic counselors, I would say that our satisfaction has also increased because initially, before this workflow, we were feeling really pressured to, if we already had full schedules for the week, to add on these urgent patients. It's really hard to say no. I think as genetic counselors, we all feel that when we know that a patient needs this and you know that those providers need this. And so it's kind of alleviated some of that scheduling pressure so that we have more cushion on the back end for when we can schedule them for post-test genetic counseling, knowing that they've gotten that initial most important genetic testing completed in a timely fashion.
One of the things that we can take away is that this has been a huge satisfaction point, and that it's increasing the ability to get results quickly and quality results for our patients, for both of you.
Absolutely. And I think, when we talk about satisfaction, I think early in the process among the genetic counselors, there was a lot of concern among some on our team that they were being replaced by a video, and they felt uncomfortable with taking genetic counselors off of this upfront process. And I think over time, that sense of discomfort has gone away because we are not taken out of the process. What we are really doing is we're offloading some of the information provision by way of video content and the logistical arrangements for genetic testing using our fantastic GTC team who really knows how to make it all work. And then for those who have clinically meaningful results, we are much more immediately available to deal with the outcomes when someone has a positive result, we can get them back on the schedule as soon as possible, and then make sure we're doing all the things as genetic counselors that we need to do going forward, and engaging the patient and the family, as we know, is important for cascade testing and beyond. And so I think it's been a process, to feel like it's okay. It's okay to use technology to do part of what we do, and it's really just a part. And we still provide a tremendous amount of education in our various roles with patients. It just makes us more efficient, and it increases access, and it places us in patient encounters where we cannot be replaced by a video.
I love that. This is not a replacement.
That's right.
It's augmenting, it's helping streamline and get quality care.
Exactly.
I also like that you said technology, because I can only imagine for both of you that there were some barriers, be it technology that you needed, funding. Tell us what barriers existed when you were putting these programs together, and how did you address them? Morgan, we'll start with you.
Yeah, so we started with, an office where there was significant buy-in from the physicians, from the staff. They wanted this to work just as much as we did. So I feel like that was really helpful, kind of setting the tone for, we're going to work together and we're going to try to make this work. We're going to, roll it out as smoothly as possible. But I would say with implementing any new workflow, there are going to be little hiccups and little kinks that need to be worked out, things that you maybe didn't think about until you went live with, the workflow in real life. And so I think, training the staff and the physicians to consent the patient, going over scripting with them in terms of what we typically review with the patient, the most important points to review about, explaining genetic testing, the risks, benefits, and limitations, and kind of going through that consent form. And then just ordering through a new portal, getting them set up on the lab portal, and making sure they're comfortable with that. Figuring out, there were some pieces of the workflow that we needed to decide, okay, who's going to get the initial stat panel results into the EMR, and then who's going to get in the expanded test results in the EMR. Making sure that the clinical team on the lab portal included all necessary parties that would have access to those test results that might need them. So little pieces like that. Overall, though, because we worked so closely together and we were in constant communication, we were able to address, any kind of hiccup that came up and correct it. And then we had come up with kind of an office protocol that we, went step by step on what the protocol is. And then we just kind of revisited that and, updated it accordingly whenever there was a modification to that.
Morgan, I'm imagining you buried in papers of operating procedures. What did that constant communication look like, especially in the dynamic setting that you're in, where you're not necessarily in the same office as these providers? How did you stay in touch?
Yeah, well, we're lucky to be very close to our breast specialist office, so I'm able to kind of pop in pretty easily. But just scheduling initial touch base meetings, and then being in constant communication via our team's, messaging or instant messaging with the office manager and staff is kind of how we've, been in constant communication.
I imagine that, Jill, you might have had slightly different challenges at a very large institution.
Well, I would endorse that all of the steps that Morgan laid out are important steps for any program to think through about how their process is going to unfold. And it's really going to vary and be specific to that institution and what's going to work best for them. As I mentioned, Dana-Farber is a very large freestanding cancer center. Last year they saw about 35,000 new patients. And so we had the benefit of being in an institution that was fully supportive of this process, since the rapid access process serves every different what we call disease center, potentially. Initially, again, focusing on the diagnosis-based guidelines for the breast, the panc, the prostate, et cetera, those patients. And so they supported us in coming up with the video, funding the production, working with a professional team, coming up with the content, literally storyboarding the whole thing, working very hard on the language, making it understandable. And then the actual implementation of the protocol, as Morgan was laying out, is just a multi-step process that has to involve all the participants from the beginning, including our new patient scheduling office, to training the genetic testing coordinators in a role that they hadn't had before, making sure the providers, our physicians, our NPs, our PAs, everyone knew what this process was about, getting input from what would work best. It took many months of planning, close to a year, to finally come up with and have a product that we could use and people trained to roll it out. And so planning, planning, and there's almost so much you can do in advance, and then of course you learn along the way and you take stock. And if you have to zig here or zag there to make it work better, then I think that's important too. No matter how much work you put in advance, you have to be practical and then adjust as you go.
It sounds like both of y'all have a very solid process that also involves non-genetic counselors. What did the training look like for the members of your team that weren't genetic counselors as part of this process? Morgan, maybe you can start.
So I've worked really closely with our breast specialist for quite a long time, just in sitting on tumor boards and educating them on genetic testing. But I did work with the office manager and staff of the breast specialist to make sure that they, understood kind of what the briefest version is to explain the most important details of the risks, benefits, and limitations of genetic testing. And I kind of explained to them how I go over the consent form with the patient when they sign that. And so it was just some kind of more hands-on training with the office staff and breast specialists to make sure they kind of understood the scripting that we typically use as genetic counseling as part of the consent process.
Jill, how does that compare to what your group has been doing?
In implementing our program, we really got everyone involved who's going to be touching this process right from the get-go to gain an understanding of really what would work and what was practical, what would not work. So it included our administrative team, it included our new patient schedulers, it included all of our different, what we call disease centers, the different specialty practice areas that see these cancer patients, to make sure everyone's viewpoints were considered. And I think this is, part of how everything needs to be really set up according to what's going to work best at the institution, because it's certainly going to vary from one place to another. So we had a number of meetings held over many months to try to consider different ways of doing this process. And so our front point of contact, our new patient coordinators, are very instrumental in getting this process going, because they're finding people who are candidates for the rapid access process. And we have further scrutiny where, based on the patient's insurance, maybe they won't have genetic testing paid for unless they meet with a genetic counselor. Our NPCs know that, and they know to not set them up that way to optimize, reimbursement. We know that if there's a mutation in the family that's known, then those are not folks who will go through the rapid access process. So getting everything set up from the front end to then training the genetic testing coordinators, who again were genetic counseling assistants, already very familiar with how to manage the portals and putting the information in. We're not used to interacting with patients before and going to clinic, and so there was training involved in how do you do that. We did mock sessions, just like we as genetic counselors all did in our training process. And at many centers, the GCAs are now our GTCs, are folks who have interest in becoming genetic counselors. So it's really been a wonderful role for these folks. Training the physicians about the process was a very key part, knowing that their patients were going to be offered this testing on day one of the appointment, knowing that it's very helpful if they discuss genetic testing with their patient at these new patient appointments, because they had assumed, all along the genetic counselors do that, and there's obviously great benefit in having this introduced first by the physicians before meeting with the genetic testing coordinators. All the way down to figuring out, as you were saying, that the workflow about how the information gets loaded into the electronic medical record, ensuring that the results get pushed out to the team in a very timely way, as well as to the patient, and that all follow-up steps are set up in advance so that the right people ultimately are going to get the right care.
Some providers think that the direction we're heading is that at some point, all patients with a diagnosis of cancer might be recommended to have genetic testing. I'm curious, Morgan, specifically for your group, how do you see this as being scalable to other specialties? Would it work?
Yeah, so I also feel that way. I feel that that is not too far away. So we have expanded this workflow into our colorectal surgeon's office. So, about a year ago, the NCCN guidelines, changed to say that all colorectal cancer patients, regardless of age at diagnosis or family history of cancer, should, consider multi-gene panel testing. And so because of the success and, increased satisfaction with our breast cancer workflow, we decided to try to roll that out in our colorectal surgeon's office. And we were very fortunate in that there was also significant buy-in in this group as well. And so now all newly diagnosed colorectal cancer patients are offered multi-gene panel testing. It's a colon-specific hereditary cancer panel, but otherwise, it's a very similar workflow where at their initial consult with their surgeon, they are offered genetic testing, and if interested, they're consented. A blood sample is taken at that time and then sent out, and then they are referred for genetic counseling on the back end to review those results and then offer additional genetic testing based on the family history. And so far, it's been, just as successful as the breast cancer population in that our volume, the number of patients that are undergoing genetic testing and counseling from this population has significantly increased. We were really missing a lot of these patients just with our kind of, the flaws in identifying these patients and getting them to a genetic counselor and doing genetic testing if appropriate. We've also identified a lot of patients with germline genetic mutations in this population that would not have been identified if we had been relying just on age at diagnosis or a family history of cancer. So it really kind of makes me think, how many other patients are we missing that have underlying genetic mutations? And I definitely think that the time will come when all cancer types are recommended to have, probably paired germline and somatic testing. The way I see it, it's like if your institution is staffed well enough that you can do the traditional genetic counseling workflow model and see all of these patients up front and offer genetic testing, that's great. If you are not set up for that, what solutions might you be able to put in place that would help support your team of genetic counselors, help support your clinicians, and ultimately ensure that all appropriate patients are being offered genetic testing?
And we know that's happening everywhere right now. We both at a large institution, but also at a smaller institution, that this bottleneck of needing to make sure that our patients have quality access to rapid care that changes treatment seems really important. I can only imagine, as you have both been putting these programs together, that you have gone through a lot of different iterations, and you probably have a lot of advice to give people who are considering doing this for themselves. What would be your top pieces of advice for people considering alternative service delivery for genetic counseling? Jill?
Brian, that's a great question, and I guess I would start with, there is really no one right way to do this, and I would encourage genetic counselors who have listened to Morgan and I talk about our programs. It's not the only way either. There's other ways beyond what we have sorted out, and to think about what is most likely going to be successful at your own institution based on what are the professionals who are there, who are interested, potentially, who would be good at this process. And it can be a variety of different practitioners. It doesn't have to be, exactly the way we have laid it out. So to consider who your assets are, who's there, who can be brought into this process successfully, and then really to think about all the players along the way, that it's not just the genetics team coming up with this process, but it's everyone that we interact with in cancer care for these patients that will be touched by this process, and to get their input, to get their recommendations, understand their concerns, and then to stay in constant communication over time, and make sure even little things like the number to call, to get someone into this process is widely available on your website, or whatever way you're going to make it, have something tacked up in clinic, on the wall. There are lots and lots of ways to help ensure the success of your program, but thoughtful planning that is particular to your institution and not just trying to emulate what someone else has done. Thinking about the comfort in using alternative technologies like videos or chatbots, or even other ways of communicating information, how you can integrate that into your process, as well as the whole flow of ordering the testing, what you're going to order, how results will work, what your follow-up will look like. And so I would just encourage people to be thoughtful and not worry that it doesn't emulate exactly what someone else is doing, because there are lots of creative genetic counselors out there that can really, I think, come up with something that we maybe haven't even thought of yet that's going to really enhance this process.
And you've been very consistent today. Communication, buy-in, your stakeholders. It sounds like people who focus on that are going to have a lot of opportunities of different service delivery that they can explore.
You want people to think this is a good process that's going to help their patients. It would be terrible to start a new process with concern or resentment or some sort of issue that you could have worked out up front before your process rolled out. And so yes, Brian, I completely agree. Communication is absolutely the key. Planning and communication, and then revising.
Your programs have been so successful. Morgan, what does that same advice look like from your take?
Yeah, I would echo what Jill said, that there's no one-size-fits-all approach, and every institution and every department within that institution might have slightly different needs or slightly different workflows that are going to work best for them. And so really being thoughtful about, creating a process that is tailored to that specific office or department where you're going to roll that workflow or alternative service delivery model out in, and then just being aware that there are going to be hiccups that happen, and there's going to be modifications that need to be made to make the process smoother, and that change is inevitable. As we continue, having increasing indications for patients that need genetic testing, and as that volume continues to grow, and as we try to scale to meet the needs of all of these patients, those workflows might need to change as well.
Morgan, Jill, thank you again for your time. Your insights today, your expertise in this, everything you've brought to us has just been a wealth of knowledge, and giving us insight into how you've used different workflows to ensure greater number of appropriate patients are being offered genetic testing and counseling, and more importantly, for sharing some of the challenges or changes you've had to work through so that others considering similar workflow models can learn from your experiences. We appreciate you both coming. Thank you.
Thank you. Thanks. This is great.